Good evening. I am Dr. Paul Stanislaw, and thank you for joining us tonight. Tonight we're going to talk about injectables and fillers. Tonight's topic is all about what you need to know before you have a Botox injection or a filler injection, like a Restylane or a Juvederm injection. There's all sorts of products out there. Tonight we're going to we'll start with the neuromodulators. Neuromodulators is a fancy term that encompasses the Botoxes and the Dysports out there. Now, Botox is sort of the brand name that everybody knows. It was the first one that was FDA approved for wrinkles. So it has become like the Q-tip. Every cotton-tipped applicator is called a Q-tip. So when I talk about Botox tonight, it's the same for Dysport and any of the other neuromodulators. So what is Botox? What is Dysport? They're two separate companies. They are like Coke and Pepsi. They both have the same active ingredient. They are protein complexes that affect the nerve, and they stop the nerve from sending a signal to the muscle. So for Botox, everyone thinks of it, it's a toxin. I'm afraid I don't want to have Botox because it's a toxin. The neuromodulators, the Botox and the Dysports, they are the safest things that I do by quantum levels. Everybody comes in with these preconceived ideas and they really don't know. But in reality, Botox can't give you an infection. It can't hurt your skin. It can't, it doesn't hurt anything permanently. It goes away after a certain amount of time. And so it really is the safest thing that I do by far. But everything I do has risks, and we're gonna go over the rest of the neuromodulators as well as the rest of fillers and such. So Botox is good for wrinkles that are what I call dynamic wrinkles. So if you look very closely on my forehead, this area is called the glabella, and if I scrunch really hard, those muscles contract, and you can see those depressions, those furrows in my glabella, the 11s. So that's when I contract and I see those wrinkles, I call those dynamic wrinkles. Now, if you look very closely, I also have what I call static wrinkles. I have wrinkles that are there at rest, regardless if I'm contracting or not. Botox and Dysport, only neuromodulators as a whole group, they only help with dynamic wrinkles. They will not fix a wrinkle that's embedded in the skin already. So once the wrinkles become embedded, it's a static wrinkle, then it becomes a filler when you have to inject filler into that wrinkle and sort of mold it and shape it. So for people who have dynamic wrinkles in their glabella, the forehead, and these wrinkles are the ones that go across here. They're made from the frontalis muscle to raise up their eyebrows, the crow's feet. So these three areas are the 95% of the time when you inject Botox or Dysport, it's in those three areas. Other areas that we do sometimes we'll do the upper white lip, just a little tiny bit. When people have wrinkles, we'll go over that area too. And then sometimes we'll do it in the platysma, the bands that hang down underneath of the neck that go down this way. Sometimes people have very dynamic muscles that are there that pull down, and they give those people the bands, and we'll inject Botox or Dysport there. So when we inject Botox or Dysport, it's done in the office. It's a very quick procedure. It's very easy. Yes, there is a needle that's involved with this, but it's a very tiny needle. Some people who are very sensitive to things will put topical numbing medication on them beforehand to sort of numb up the skin, but I will tell you that 98% of patients don't use topical numbing medication because it's over so quickly, they just do it. So when we have patients that are concerned about this area, okay, from these muscles contracting, basically there's a muscle that goes this way and a muscle that goes this way. They're called the corrugators, and right down here is the procerus, which gives you the wrinkle that goes right across here, okay? So when people don't like that, basically we'll inject it into these muscles right through here to stop those muscles from moving. Here and here, so the crow's feet and the glabella, We want to knock this out completely. We don't want to have any movement when we frown or get scrunchy and be mean. We don't want any movement out in our crow's feet here. So those two areas, we like them to be completely quiet. The forehead is a completely different area. So the forehead is very important. It raises up your eyebrows for expression. So when you're surprised, you're mean, angry, these eyebrows need to move, and those move from these muscles right here. So when the vast majority of people, when we do the forehead, our goal is not to knock it out completely, but it's to soften it just a little bit. Okay, so we want to soften it so they can't make the wrinkles as deeply as before, but we still want to have a little bit of motion to raise up the eyebrows. There is a small percentage of people that like it completely quiet. They want it out completely. There's nothing wrong with that. It's a perfectly fine choice, but not everyone can do it where it's completely out. Okay, and we'll go over who's a good candidate for the forehead and who's not. But for this area, most of the time we want to have a little bit of motion, and we achieve that with using a little tiny bit. Now, the way the neuromodulators work is that we inject the medicine into the muscle, and it doesn't really affect the muscle. It actually affects the nerve that sends the impulse to the muscle. So the neuromodulator, the protein that's in Botox or Dysport, gets incorporated into the nerve, and it stops the nerve from sending the signal to the muscle. Now, it takes a couple days for that to happen. Botox and Dysport they're not instantaneous. It doesn't quickly freeze it. Botox takes a little bit longer. It takes about 7 to 10 days in my experience to kick in. Dysport kicks in a little bit quicker. It's more like 3 days for it to kick in. So it takes about 3 days for you to see the results. So you inject into this area, and over the course of those 3 days, you're going to see this start to, you're going to try to scrunch, and it's not going to scrunch. It's not going to move, okay? Now, Botox lasts and Dysport lasts about 3 to 6 months. There's a lot of variables with that. It depends on the injection technique. It depends on how much Botox or Dysport was injected. Depends on the person, okay? So it depends on the area within the person. Now, in my personal experience, I find that the crow's feet area comes back online. The Botox wears off here the quickest because this nerve is sort of the more robust nerve. It has a very important job to close the eye. And so I think evolutionary-wise, it's learned how to be very robust, and it fixes itself very quickly, and it comes on earlier than the other areas. In regards to the forehead, right? When we are doing the forehead and we only want to soften it a little bit, we only soften it, the way we soften it is by putting just a little tiny dose and spread it out over a large area. Now, what does that translate to? When we do a little amount and we do it over a large area, it doesn't last very long. If you put a lot in, right, it'll last you for 6 months, but if you put too much in there, it's gonna make this feel really, really heavy, and you're not gonna be happy with that. So, again, it's just showing that depending on how much you put in an area will sort of determine how long it lasts for. So we're going to talk a little bit about each area specifically. So the glabella, funny term, Glabella. Glabella is just the area between the eyebrows. It's the 11s that people talk about. We'll inject here. It's probably the most common place that we inject. This is the place that people see the most, okay? Lasts probably more about 4 or 5 months. This area tends to last quite a long time. It's very easily injected. There is a very, very small risk when people have this area injected of having a little headache there for a couple days. I see that more with Botox and Dysport, but again, that's my personal experience with that. But their incidence of having a little headache after an injection here is maybe 2%. It's really very, very low. It's a pretty rare thing. It doesn't mean anything's bad. It just means that just like you get a shot in the arm for like a flu shot, it aches. Sometimes it aches there. But that's a pretty rare event. Very well tolerated. Again, probably the most common area that we inject. There's no real contraindications to doing this area. Like pretty much everybody can do this. It doesn't, knocking this out doesn't hurt anything. The risk with doing this area though, is if you accidentally intravascularly inject it, if you inject it into a blood vessel in this area, okay, the product can reflux back down into the blood vessel, and it can affect the muscle that lifts up the eyelid. So if you think of the eyelid as like a garage door, and there's a garage door opener on the inside of the garage, there's a little muscle on the inside of your eye there that lifts up your eyelid and closes your eyelid. Well, it doesn't really close it, but it just relaxes. So if that medicine gets to that muscle, it sort of short circuits the garage door opener, so it doesn't lift up so much. So that eyelid can be a little heavy and get down to the pupil. That's a pretty rare event. Again, it's from accidentally getting a little bit of medicine into that blood vessel. I've been doing this for 22 years. In 22 years, I've had it's happened nine times for me, for my patients. In all 9 times, it only lasts for 3.5 weeks. So even though the product may last 3 to 6 months up here, the heaviness only lasts about 3.5 weeks. And why is that? Because it's only getting this little tiny dose, and it goes away pretty quick. The nerve recovers pretty quick. It will always go away. You don't ever have to worry about it permanently hurting anything. Again, with Botox and Dysport, I've never seen an allergic reaction. It doesn't hurt anything, doesn't hurt the skin, can't block a blood vessel, can't get infected. So very, very safe. For the crow's feet area, and this area rarely bruises. It might bruise, but it's pretty rare. It's not very common. Maybe 5% of the time you can get a bruise right through here. For the crow's feet area through here, okay, so there's a muscle that wraps around your eye called the orbicularis oculi, and its job is to close your eye. And when it contracts, it causes wrinkles in this area. So in the beginning, just like here, the wrinkles are only there when the muscle contracts. They're only dynamic. Over time, as we age, the wrinkles start to become embedded, and then they become embedded at rest, meaning that they're static wrinkles. They're there regardless if you Botox this, if the muscle contracts, there's always little wrinkles that are there. So again, Botox Dysport is for the dynamic wrinkle, for when people smile and those muscles contract. You inject it all through here, right, into this muscle that wraps around there. And it's not just one shot, unfortunately. This muscle's it's about a 1/2 inch wide, wraps all the way around, and you have to sort of march the stuff all the way around there and get every little aspect of it. So all of it is weakened uniformly, and it looks much more natural, and that's how I do it, by just doing that whole area through there. The downside to that, of doing little shots all over the place, is every time I put that needle in, there's a chance I bruise you. This skin is very, very thin. It bruises very easily. Okay, so it can bruise really easily. So I tell people the risk about a bruise there is about 20–25%. I hate when I bruise people, but it's unfortunately part of the thing. There's the risk of I bruise you. Again, takes about for Dysport about 3 days to kick in. Botox about 7 to 10 days to kick in. Lasts about 3 to 6 months, but again, it's a little bit on the shorter side because this muscle comes online quicker. The risk with doing this area, okay, is that there's muscles that go from the corner of your mouth to your cheekbone, right up through here, called the zygomatic major and minor, and that muscle ends right where the orbicularis oculi, this muscle that wraps around, they come really close together. So if any of that medicine gets into that blood vessel, be it an intravascular event where a little bit's injected into the blood vessel but affects that muscle, it can weaken your smile. So it could give you an asymmetric smile. That's really rare. In 22 years, I've had 2 patients where that's happened, and in one of those 2 patients, it's happened twice. So there's just some anatomical difference for that person where if I inject it in my usual place, it sort of knocks out that muscle. Again, only lasted 3.5 weeks, so very, very limited duration, but that is the risk for doing this area, in that it can do that. Again, very, very well tolerated. The skin, because it's so thin, after the injection could have like little dots there for a day or 2 that you might have to throw a little makeup on. Not bruises, but just little dots. Right after the injection, when you inject this medicine in there, it'll be a little bit of a, looks like a little mosquito bite because of the fluid that's there, and that'll dissipate in about 20 minutes. Now, for this area, all right, so there's another neat thing that you can do with Botox or Dysport in this area, in that as we age, our brows often fall, going down here. This is called lateral brow ptosis, hanging down. In patients where that's heavy, the treatment for that, there's two treatments really for that. There's a non-surgical treatment and a surgical treatment for that. And the non-surgical treatment for that is a Botox or Dysport injection. Now, how is that done? The muscle that wraps around the eye, the orbicularis oculi, that gives you the crow's feet, its job also protects the eye and it brings the eyebrow down. So it's a depressor muscle. The forehead muscle here is an elevator muscle. It's trying to raise your eyebrows. And those two muscle groups are always in tug of war. One's trying to pull the eyebrow down, one's trying to lift it up. Now, what you're doing is you're injecting into the depressor muscle with the Botox or Dysport. You're selectively weakening that muscle. So in that game of tug of war, the forehead muscle is now unopposed and it can pop the eyebrow up, okay? What I tell people is that your homework after that injection, if I inject it through here, is to pay attention, because it might lift this up. That doesn't mean it will. It might. There are some people that are just so heavy that even when you do that, it won't lift it up enough. And it's also not making this muscle any stronger. It's only weakening this. So we're depending on how strong this muscle is in response to that. And if this doesn't lift up anymore, you're not going to see any improvement. So I tell people, do it once, see how it is, live in it, pay attention. If you feel like it lifts it up and it makes this better, then it has value, then it's worth continuing over time. If it looks exactly the same, it doesn't do anything, well, guess what? You tried, there's no harm, no foul. It didn't work, now you know, well, the only other way I can do this is with a surgical brow lift where I make incisions up here and lift this up. Okay, so that's how I do a non-surgical brow lift, by injecting this area. There is another way to do a non-surgical brow lift with Botox, and we're going to go into that. I don't do it this way because I think that looks the other way looks kind of artificial. So we talk about the forehead muscles raising up the eyebrows, right? So what people will do is they'll inject Botox or Dysport into the center area of the forehead, selectively weaken the muscles here, but leave these muscles over the lateral aspect intact. So you weaken this, and what does it do? As it weakens this, it makes this heavy, and it drops this down. So as it drops the medial portion of your eyebrow down, by relationship, it's making the lateral aspect look higher, right? So you didn't raise this, but you actually lowered this. So that's one aspect of it. Then subconsciously, you feel heavier, like you feel like this is down. So you're trying to raise your eyebrows up. You're trying to do your own brow lift, your compensatory brow lift with your muscles. So you're lifting this up. Because this doesn't move, this whole area is quiet, but this muscle is still intact. These muscles will contract and lift this up. Now what I find with that is that gives you a very pointed eyebrow, wrinkles above your eyebrow out laterally, and everything's quiet in the center. So to me, that's a really bad way of doing it, because it's all quiet through here, looks really, really weird where this is quiet with wrinkles out laterally, and the eyebrows tend to be very peaky. So that's the other way of doing it. I don't do it, but there are people that do it. Again, that's a personal preference of mine. It's not like it's wrong or right. I just don't do it that way because that's how I feel about that. So that brings us to the forehead, okay? So a lot of patients will come in and they will be, I hate these wrinkles, right? They're there, I hate them, they're dynamic, they've become static to a certain degree. There's wrinkles that are embedded in the forehead even when they're not raising up their eyebrows. And they're so heavy. Their brows have sagged so much that they need this forehead muscle to raise up their eyebrows just for them to see. Because again, as this sags, subconsciously we feel the eyelid skin resting on our eyelashes, right? And what do? We raise up our eyebrows. So in the morning, all day long, we're using this muscle all day, giving us the wrinkles. And by the end of the day, this muscle starts to fatigue, can't raise this up enough, and it starts to sag and you start to look tired. So the, let down a little bit, not working. So as this sags down, right, this makes you look tired. Now, those patients, they don't realize that they're heavy here. They just, all they see are these wrinkles. So those patients can be so dependent on that forehead muscle that if they come in and say, I want my Botox, and you go and you do the Botox there, and even if you weaken it just a little tiny bit, it weakens it so it can't compensate anymore, and it drops you and makes you heavy, okay? So there are some people that are just not candidates for it. Like all they see is the wrinkles. They don't realize that that wrinkle is a secondary response. And if they do this, it'll make them heavy and they'll be really unhappy. It'll go away. It's not the end of the world, but they just will feel like, I can't raise up my eyebrows. It just looks tired. I just look tired all the time. So when people come in consultation for that, I'm always looking for that. I'm looking to see how heavy their eyebrows are, how dependent they are on that forehead muscle. And if they're like, I really, and I see them and I see that they're very heavy, I will counsel them and say, you really can't do this because that's not a good idea. And then that brings us to the brow lift idea, right? So they're really heavy, they've got these wrinkles, but they're heavy in their brow. And so we sort of talk about, well, you could do Botox here and try to get this to pop up so you don't need to use these forehead muscles so much. The thing is, though, is that you can't have it both ways. I can't get the brows to pop and then Botox this away. Because if I Botox this and I Botox this, it's a net zero. There's no elevation. So to do a brow lift, a non-surgical brow lift, you need to keep these muscles 100% intact, lifting up for that to work. And a lot of people have to decide, what's more important to me? Is it the wrinkles here or is it the brow? They have to make that decision. When patients aren't heavy, okay, they don't have any brow ptosis, they're not really dependent on here. Basically, we're going to talk about, well, what's their goal? The majority of patients' goals are just to soften this a little bit. I want to still raise up my eyebrow. I don't want to look frozen. And in that situation, again, we'll take a little tiny dose of Dysport or Botox and inject it in multiple places across the forehead evenly and spaced out evenly so everything is softened. It's not like one big quiet area and this area is moving. Everything is softened uniformly across the forehead. They still can raise up their eyebrows. Again, doesn't last very long, but you're only paying for the product that we put in. Now it does cost you in time because now you have to come back every 2 to 3 months. Okay, it's not going to last you 4 months or 5 months or 6 months. It really becomes 2 or 3 months. You're coming back and we're touching that up. So it costs you in time, but it doesn't cost you any more in product. There are definitely patients out there who want it completely quiet, not moving, out, solid. They don't ever want to see it to move. Again, they have to have the correct anatomy, correct eyebrows to achieve that, for that to work. And as long as they do, it works very well. And it's not that it's right or it's wrong. It's just that's their preference and it tends to work for them. But in that situation, you're using a larger dose, you're still distributing it evenly over the forehead. Okay, so that's for the dynamic wrinkles of the forehead. Okay, so once again, we talked about the glabella, the forehead, and the crow's feet. Now, for the upper white lip, okay, patients will come in, they will be in their 40s, and it's usually women patients, and they will come in and say, I hate the wrinkles on my upper lip. And I'll be in there and I'll put my glasses on and I'll look real close and I'm like, yeah, okay, what wrinkles are you talking about? And then they'll pucker. And when they pucker, all of a sudden you'll start to see these depressions and wrinkles in the upper white lip. So again, dynamic wrinkles. They're not static. They haven't become embedded. As women get older, the skin gets thinner, loses its elasticity, loses fat in that area, bones change, and then over time, those wrinkles become embedded at rest. So they don't have to pucker and they're embedded. If they're embedded, again, they're not candidates for Botox or Dysport, no neuromodulators. At that point, it becomes a filler injection, and we'll talk about those in a little bit. So the woman who comes in, 40 years old, there's nothing embedded at rest. It's only there when they pucker. What do? All right. So first step, they're losing their elasticity. So we have to counsel them and educate them into wearing a good quality sunblock with zinc oxide every single day. Just buy a medical grade one that goes on clear. It's micronized. But the better you are at maintaining your elasticity with a good quality zinc sunblock, doing your antioxidants like retin A, vitamin C, and vitamin E topically, the longer you'll hold on to your elasticity and the longer it will take for the wrinkles to become embedded. Okay? That's sort of the best we can do. I can't stop the changes in the fat. We're just trying to hold on to the elasticity as best we can. So what we'll do when they have those, when they pucker, as long as they're doing those things, well, you don't have to do that, but it's a good idea to do. Some people don't do it, and we still do the Botox injection or Dysport injection. So I'll have them pucker, and I'll do this little tiny dose into the white lip, above the red-white margin. I'll inject it in there. The goal of that, again, just like the forehead, is to soften it just a little bit. I can't knock it out. If I put too much in there and knock it out, you can't pucker, you can't drink out of a straw, you can't whistle, your smile's not right. So it's this little tiny dose that goes into this area. Again, doesn't last very long because it's only a little tiny dose. But again, a nice thing to do. It does slow down the wrinkles from becoming embedded, and we're going to talk about that in just a little bit at the end. But you can do a little bit here. Risk is you put too much in. I can't whistle, I can't smile, I can't pucker. Risk is if you get into a blood vessel and it knocks out a little bit more muscle on one side than the other, could you have an asymmetric smile? Yes. The risk is, and this is true for all the Botox things, is that, my expectation was that it was going to do more. I do it, it's working, but man, I thought it was going to knock it all out. It's all going to be gone. It's not going to make it all gone, okay? When we do this area, we're just trying to soften it. It won't make it all gone. So I don't really consider that a risk. I consider that a failure of educating the patient into reasonable expectations. So that's for that area. Another area that's rarely done, but it is, you might see it out there. So for the corner of the mouth, right? They're all muscles all around the mouth, and their job is to smile, pucker up, and move it. But there's one muscle, and the abbreviation for it is DAO. DAO muscle's right here, and its job is to pull this area down. So in some patients, you can inject a little bit of Botox or Dysport, a tiny bit, into that little muscle there so that this doesn't pull down so much, and it might pop up the corner of the mouth a little bit. Problem with that is that it's not super cost effective or time effective because you can only put the tiniest dose in there because otherwise it'll change your smile. So you put a little bit down there, might work a little bit. Again, there's a chance of a bruise, chance of asymmetry, but sometimes you'll inject a little bit there just to get the corner of the mouth to pop up a little bit. For me, I feel that fillers into the marionette lines in the corner of the mouth and spackling it out with fillers for the embedded static crease that's here is a more cost-effective, more time-effective way of treating that. But there are some patients where we'll put a little Botox down there. The last are the muscles, the platysma muscles, the bands that are right here. So there's a thin muscle right here and a thin muscle right here. It's a thin sheet of a muscle, and it's called the platysma. And when we're young, and the edges of the muscle are not fused together. Those muscles have a little gap to them. And when we're young, they're tucked up under our jaw. And as we age, they start to sag down. Now, when the muscles are sagging down and you have these bands, they're just saggy because we've aged and things have fallen. Botox won't lift that up. All right? Botox doesn't lift. Dysport neuromodulators do not lift anything. They only paralyze. They only weaken the muscles, okay? So if I have saggy muscles hanging down, right, you could Botox till the cows comes home, and they're not going to lift that up. The only thing that's going to lift that up is surgery, okay? But there are patients where these muscles have a lot of tone. So the most common patient is the younger patient, say in their 20s or 30s, and they take all sorts of pictures, and they're thin, and every time they smile, these things pop out, right? They come in, they say, look, this is my picture. I hate this when this pops out. So those are the perfect patients to inject Botox or Dysport just into the middle part. You grab it, just inject it right into the muscles, right through there to weaken those muscles so they don't pull down. So if you think about the neck, so here's the neck and here's the jaw, and that muscle's on that curvature. When the muscle contracts and shortens, it pulls down like a bowstring, right? So if you prevent it from contracting and shortening and pulling down like a bowstring, then it'll stay up. So we'll do it there. There are some patients, older patients, where those muscles just have a lot of resting tone. So they do have a saggy event, like like those muscles are just saggy. You do a facelift on them, a neck lift on them, you lift it up, and then postoperatively, they still have one muscle that's sort of jamming down, right? And in that situation, those people just have more resting tone in that muscle. You've sort of fixed the sag, but that muscle's still contracting and pulling itself down. And in those patients, you can inject a little bit of Botox or Dysport in there and stop the muscle from contracting and get that to pop up. So in some older patients, some where the muscles are just saggy, sometimes there is still a tone contraction component to that, and sometimes they'll get a little bit of benefit from that. Once again, there's no harm, no foul. If that's the situation, you have an older patient where you think it's hangy, but it might pop up, you can inject it into there. Their homework is to pay attention, see if it works. If it works, great, then it has value, then it's worth doing. If it's still saggy, doesn't do anything, well, you tried, didn't work, now you know you gotta do a neck lift, okay? So it's a nice, simple test with the risk is you lose your money. It didn't work. This area, sometimes you can bruise, right? Because there are little veins there, you can bruise. But you're sort of grabbing that muscle where it's sticking out and just injecting a little tiny bit in those spots. And that's really about it. So the risk is that it doesn't do what you expect it to do, and you bruise, and that's about it. There's not any risk other than that. So that's the areas for that. Areas other than the face that Botox and Dysport works for hyperhidrosis, so people who sweat a lot, so people who sweat under their arms, people who sweat in their inguinal creases down on their hips or in their hands or their feet. You can inject Botox or Dysport into the skin in those areas, which affect the nerve sending the impulse to the sweat glands, and it stops that. Works very well. Works a long time for me. I find that it lasts about 9 months. So it does a really, really good job of stopping sweating for that. So people who fail the different antiperspirants, the medicines, and all the prescription ones, that works very, very well and very well tolerated for hyperhidrosis or excessive sweating. Now, people will talk about, so in today's day and age, younger and younger people are doing a lot of cosmetic procedures. They're much more engaged with their skincare. They're more educated. They want to really take care of their skin. They want to slow down. There's no such thing as anti-aging. There's no anti-aging cream. There's no anti-aging machine. Nothing's going to stop you from aging. All we're trying to do is slow the process down, all right? And basically, that's trying to hold on to elasticity for as long as we can by taking care of your skin. Now, the most cost-effective things for that is, of course, the sunblock, which you talked about in other live events, topical retin A, topical vitamin C, and topical vitamin E. But Botox and Dysport is kind of lives in both worlds, meaning that I tell people I have 2 buckets. I have one bucket that is a treatment bucket. I have dynamic wrinkles. I don't like them. I want to treat them. I'm taking care of something actively right now. And then I have a delay bucket. It's not a prevention bucket. It's not an anti-aging bucket. It's a delay bucket. Botox lives in both, meaning, so if I stop these muscles from contracting every time I contract, right? So in the beginning when I'm younger and I'm starting to lose my elasticity, the wrinkles start to show up. Over time, the muscles keep contracting, and eventually a crease will form and the wrinkles will become static, embedded at rest. Now, There are people that will say, doing Botox there, or here, and in any of these places that we talked about, that, oh, I'm going to do Botox here because I never want a wrinkle here. I don't ever want a wrinkle. I'm going to do Botox, Botox, Botox. It is true that the Botox or Dysport will slow down the wrinkle from becoming embedded, but it won't stop the wrinkle from eventually forming because other things are happening besides the creasing, the muscles contracting, okay? So for the glabella, for example, where those 11s occur, there's an anchor that attaches the skin to the muscle underneath and then to the bone below. As we age, our skin loses elasticity, like a rubber band, gets a little stretched out. It's a stretched out rubber band's bigger than a nice, good rubber band, right? So it's a little bit bigger. So the skin container's a little bit better. We lose fat in our face. This fat wants to atrophy as we get older. And the bones of our face dissolve as we get older. Just like osteoporosis, these bones are shrinking up, okay? And what's weird is it shrinks up asymmetrically. But as this bone dissolves and shrinks in, as we lose volume there, the anchor that attaches the skin to the bone pulls in. So this anchor will pull in and pull in and pull in. So even if you're doing Botox here your entire life, as this bone pulls in, that anchor is going to pull that in. As this forehead deflates and loses elasticity, it's going to fall. It's going to hit that anchor and it's going to roll over and it's going to make it look like a static wrinkle there, okay? So yes, Botox and Dysport is a good value delaying mechanism for slowing the embedding of wrinkles of the forehead and stuff, but it doesn't stop it. It doesn't prevent it, all right, because other things will happen. So once the wrinkles become embedded here, the glabella, the forehead, the crow's feet, or even the upper right lip, okay, where they're embedded at rest, whether the muscles contract or not, then we have to do another modality. We have to do something else, okay? For the wrinkles of the glabella, when they're static, right through here, there's two different types of static wrinkles. There's a wrinkle that's very superficial, like in the crease in your palm of your hand. And then in some patients, they have a hollow, like a trough, not a real wrinkle in the skin, but a hollow. And some patients have both. They have a little wrinkle in the skin and they have a hollow, okay? So in those patients, one treatment option, because you always have options, is to inject filler, like molding clay, into the trough, the hollow, and lift it up like spackle, all right? So when you have embedded wrinkles at rest, a lot of times, depending on the area, we can put filler underneath into the anchor that's holding it down, pry up the anchor a little bit, release it with the cannula, the blunt tip needle that we use, and as we lift it up and free up the anchor, we put a little filler in there to lift it up. And then if you have an embedded wrinkle in the skin, okay, then you would have to use a needle, like this type of wrinkle, use a needle and put it very superficially into the skin and put a little bit of filler into that skin to efface that. So the deeper the wrinkle, the deeper the product, the more superficial the wrinkle, the more superficial we put it. So that's how we treat that. So usually for the glabella, if someone has a depression here and a wrinkle here in the thing, plus a dynamic wrinkle, we'll put filler in here and for the static wrinkle, and we'll do Botox or Dysport to flatten that out and soften that out, okay? For the forehead, okay, so another treatment option for here, so before we had fillers and when we had embedded creases here, we used to either chemical peel or laser this area. So that's one other treatment option for there. But that has more of a downtime, little longer to heal, not as powerful as when deeper wrinkles occur. Laser resurfacing chemical peels are good for more of the superficial wrinkles, but not as powerful for the trough that occurs there. When you have wrinkles that become embedded in your forehead, now that's a tough one, okay? Injecting filler into those lines, in my hands, does not work out very well. The skin is very thin. The skin flexes a lot. So even when I use the thinnest filler and the Flexius filler, to do it in these lines that here when they're become embedded, it can look like a red little ridge for a couple weeks. Not everybody's cool with that. Some people are, as long as you counsel them, tell them, well, this is a couple week process. It takes time for this to settle down. I will do filler into those lines when I have really, really deep wrinkles here. A man with really deep wrinkles, a woman with really, really deep wrinkles. I will do the filler to lift that up because it's more the powerful way to do it. But for when they're very superficial like the hand, you really can't do that well with fillers. So when we have wrinkles of the forehead, then we'll do chemical peels or laser resurfacing with their associated downtime to help with those lines and wrinkles. When we have embedded wrinkles of the crow's feet, right, this skin is very, very thin. I don't put filler into the crow's feet lines to get rid of the crow's feet. I do filler for the tear trough, the hollow that occurs here. But I will do a chemical peel through here to tighten up that skin. You could use lasers. Lasers are fine, but the skin is so thin. Chemical peels are so safe and so elegant. They do a great job for these types of wrinkles under here. And so when we have wrinkles there, I'll chemical peel it. It does have a downtime, but that's the best way of doing it. A very good, safe way of making the skin smoother. Not making it elastic, it's just making it tighter and smoother. When you have wrinkles of the upper white lip, when they become more embedded, we'll put filler into those each individual line. Now, this area is super sensitive. There's a lot of nerves there. It hurts like the dickens if you're putting a needle in here, okay? So a lot of times we'll do is we'll have you put topical numbing medication on a half hour to an hour beforehand to numb this up. Sometimes I'll inject a little numbing medication up underneath the skin around the nose to numb it up, to make you numb. And then we'll do each individual line. So again, the wrinkle has to be embedded and deep enough for me to do each individual line. But if it's not that deep, it's very, very superficial, it might be better to do a chemical peel or a laser resurfacing. If there's lots of little fine lines that are just too small to fill, again, there's more of a downtime. So before we had fillers, all you had was either chemical peels or lasers. Since we have fillers, it gives us the option. The fillers are more powerful for the deeper wrinkles that are there, but there's still times when the resurfacing procedures are a better choice or a better option. Now, when you do these lines, again, the more superficial the line, the more superficial the line has to be. I'm gonna get a drink of water. So the needle's in the skin at each individual line. Takes time. But for me, I find that's a much better way of injecting that and fixing that. There are people that inject it a different way. Again, I'm going to talk about the different way. I'm not a fan of it, but we'll talk about it. So one way to help the lines here with a filler is with a cannula, inject underneath of the skin. So between the skin and the muscle that wraps around the mouth, there's a layer of fat. And what people are doing is putting filler underneath that skin and lifting that up. And as they blow that out, it pulls the wrinkles out, right? It's faster, it's less discomfort, it's easy, it's quick. But the problem is they have to put so much filler here to pull that out. It looks like you got a piece of white calamari stuck underneath there. It gives you this white reflective ridge through here. It looks thick. It throws off the relationship of the white lip to the red lip. Okay, so it always looks weird. A lot of patients have that done, and then they come to me, and then I have to erase it. So with the fillers, there's a medicine that you can inject into the filler and dissolve it, make it go away. So you inject it into that area to dissolve it, then those wrinkles come back, and then I have to inject it into each individual line. So by injecting it into each individual line, you're not blowing it out, you're not making it look like a big highlight. You're not changing the relationship to the structures around it. You're doing it just it's a more tedious way of doing it, but a much more natural way of doing that. So we'll do it into those lines with that once they become embedded. Now again, you know, the better you are with your antioxidants and sunblock, the longer it'll take it to become embedded. But once it becomes embedded, it's going to be either a chemical peel, a laser resurfacing, a series of microneedling, but it'd have to be a lot of microneedling, chemical peel, laser, or filler to each individual line. So I'm running out of time. I know my plan was to do a neuromodulator talk by itself, not with fillers, but this has got it advertised as injectable fillers. So we're going to talk a little bit about fillers. It's not going to be in depth about fillers, but we sort of touched on those applications. So when you have an embedded deep crease, you're going to put filler in. So when you have marionette lines, right, there's a hollow, it's filler, right? So everything really down here is mostly filler. So smile lines, marionette lines, these can be called nasolabial folds or marionette lines. Marionette lines here, melolabial folds, I'm sorry. Under here, we can lose volume here and we can get a crease through here, and I call that a malar crease. Again, there's an anchor there as the bone dissolves backwards as we age. That anchor pulls in it, gives us a crease, and it makes it look like we have a bump here called a malar bag. It's good for tear troughs through here, right? So if we want to make volume, fill a void, hide a shadow, address where an anchor is pulling the skin in, it's going to be the use of a filler. Fillers are, there's many different fillers. The most common fillers out there today are products called hyaluronic acids. Hyaluronic acids is just a scary, crazy term for a bunch of sugars all stuck together in a big, large molecule, and those sugars act like a sponge. They hold on to 1,000 times their weight in water. They just want to expand and swell. So they're clear gels, okay? Now, that hyaluronic acid or that clear gel is all throughout your body. Everybody's body makes it. It's all over. If you think about it, if you just, like the example that I give is your eyeball. Your eyeball's filled with a clear gel. It's got a whole bunch of hyaluronic acid in there. Your body has enzymes that make the hyaluronic acid, and your body has enzymes that break down the hyaluronic acid, okay? So there's always a turnover, and the natural hyaluronic acid in our body turns over every 12 hours. We're making new stuff, and we're dissolving the old stuff. People take the gene out of a person, they put it into bacteria, and then bacteria make the hyaluronic acid. Okay, so it's not human, it's not animal, but it's bioidentical to the stuff that's in us. We do tweak it so it lasts longer. If it just lasted 12 hours, that would suck. We wouldn't be too happy with that. So we cross-link those molecules so that they're tougher, they last longer, depending on our application. So those clear gels, those little bottles like that, so that hyaluronic acid in that little syringe, that's the same in me, same in you, same in a chicken, same in a frog. Those sugars are the same, okay? So there's no skin tests that need to be done. Again, there's many companies that make hyaluronic acids. The major players are Juvederm, which is the Botox company, and Restylane, which is the Dysport company. So it again becomes Coke and Pepsi. They're both good products, but they both have many different flavors. So just like there's Coke Zero, there's Diet Coke, there's Coke Cherry Coke. Both the Restylane products and the Juvederm products have many, many different variations. I'm a fan of the Restylane products for a variety of clinical reasons. I feel that they're more predictable. Especially when you're working around the eyes and stuff, I don't want things to swell a lot, right? So what's nice about the Restylane products, because remember, they are sponges, they all swell the same amount, 2.8, 2.9 times. So I can predict how well and how much to put in a certain area. So they all come in, both companies, both things, they come in thin, medium, and thick. They come in versions that are more flexy. So they have stiffer versions and they have more flexy versions, softer versions. For example, the Restylane products, they have Restylane Kiss, which is a softer, flexier one that is marketed and FDA approved for lip enhancement. It's a great product for that. Very soft, patients like it, very flexy, very much more natural. If you take the harder, firmer stuff and put it in there, stiffer, the tongues are the whole lips are a very tactile area. You can feel bumps more. So we have different flavors for different applications. The way I describe it is if I'm injecting a filler into a cheek, just per se, there's fat in there, I inject it into there. If I inject something that's a thin filler, it's more like injecting water in there. That filler will flow through around those cells and just spread out. If I inject a really thick filler, it's like injecting peanut butter in there. It's going to stick there. It's going to give me more mechanical lift. It's going to give me more bang for the buck. It's going to be stiffer. It's going to last a little bit longer. So if I'm trying to lift something and I'm trying to keep the filler right where I put it, I'm going to use a thicker version. If I'm putting something in an area that needs to be smoother, I might use a thinner version. If I'm putting something in an area where it flexes a lot, like out here, where when we smile it flexes, or the forehead, like I talked about, if it flexes a lot, you'll use a more flexy version of those fillers. So there's all different flavors of that. Now, I only have 9 minutes. I'm going to talk a little bit about the risks of fillers, right? Because we talked about putting fillers here, we talked about putting fillers here. So I'm just going to go over the risks of fillers. So again, people come in and say, oh my God, I don't want to do Botox because it's a toxin, but I'll do fillers. Fillers have risks, greater risks than the neuromodulators and Botox and Dysport, okay? So once again, you inject a filler. It's like molding clay. I'm putting spackle in there and I'm molding something and I'm trying to make a smooth surface, blending out the shadows. And we'll have another talk about fillers probably next time. I don't know when we'll do it, but we'll do it sometime soon. So fillers can give you lumps and bumps, right? So risk is I do here or somewhere and I have a lump or a bump. Well, I can massage that, I can mold that. When I say mold it, it's just taking like a Q-tip and rolling it over and I can flatten it out. So I can flatten out most bumps if they happen. If I can't mold it out, I can't squish it out, I don't like it, we have a medicine that we can inject into the filler and dissolve it right away, right? So remember I talked about the body, it has enzymes that make the hyaluronic acid, we have enzymes that break it down. Well, the enzyme that breaks it down, we take that gene, we put it into a different cell line, and now we've got a little bottle of medicine that we can inject into the filler and dissolve it and make it go away, okay? So why these hyaluronic acids have become so popular is because they are the safest short-term and long-term, meaning that if I do it, I don't like it right away, I can dissolve it. If I do it and 6 months later, 8 months, 10 months, 5 years later, I don't like it, I can dissolve it. I can still make it go away years later. So as your face changes, something that looked good before might not look good 5 years from now. So we can mold it, we can shape it, we can dissolve it, which you really can't say about your own fat. You can't say it about any of the other filler injection, synthetic fillers. The hyaluronic acids have become so popular for that one reason. We can get rid of it. So super important. So lumps and bumps. The next thing, the risk with it, is that that gel is a foreign body. So if we inject it into someone's cheek or somewhere, and if it got infected, okay, if bacteria got in there somehow, the bacteria would go around the foreign body, the filler, the gel. It would attach itself to the gel and make a biofilm, a fort around it. So say you had an infection with the filler. You put them on antibiotics. It kills all the bacteria that are outside that fort, outside of that biofilm. They die, right? Oh, I'm getting better. My infection's going away. The antibiotic stops. the bacteria that are stuck in the fort start populating again and jump out, and the infection starts right up again. So if you ever had an infection, you have to dissolve every last drop of that foreign body, get rid of all their options for making forts. You have to dissolve it all, plus put you on antibiotics to get the infection under control. The longer it takes to get the infection under control, okay, the more scarring is going to happen. The infection is going to hurt the fat, it's going to hurt the skin, and you're going to have scarring. And I'll see patients come to me with those infections, and usually it's been 2 weeks. Like they go to the place where they had it, they don't know how to handle it, they go other places, they put them on antibiotics, keeps coming back. So by the time they get to me, it's 2 weeks have gone by, and now they've got scars and they've got problems. And then I have to try to fix it and make that go away. So infection is one risk of fillers. The other risk of fillers is intravascular injection, right? And so if I have a blood vessel and I inject it into the blood vessel, the gel can flow downstream of that blood vessel. It can embolize and kill everything downstream of it, okay? So there are cases where, like case reports, right, where people inject like the smile lines. There's a blood vessel that goes here that does the nose and the forehead. They inject it here, kills all the skin of the forehead, kills all forehead and all the skin of the nose, okay? When I put filler up around the tear troughs, people's like, oh my God, I could go blind. Or through here, like one of the risks with doing filler here is a risk of going blind. If there's a blood vessel you inject into it, can make you go blind. The fact of the matter is that there are case reports of people going blind from filler injections anywhere in the face. Down here, anywhere, there are case reports of people going blind. Luckily, and thank God, those incidences are very, very, very small, right? Now, I can tell you that I take those risks very seriously. I do everything I can to mitigate those risks, right? But I can never, ever tell you that the risk is zero. Now, I've never made anybody go blind. I never killed anybody's skin. But I still can't tell you the risk is zero, okay? Those cases do happen. Now, luckily, again, I'll see people with infections a couple times in a year, but I have luckily not seen anyone with dead skin or anything like that happen. So that incidence is very, very rare. But it is a risk, right? So we talk about, like, how do I mitigate those risks? Well, oh my God, I thought you couldn't do it here and you can't do it here. Well, it depends on the person's comfort level and their training. So how do I mitigate risk? Well, first of all, if I'm going underneath the skin, most of the time I use a cannula. So a cannula is a needle, but it's a blunt tip. It's just a round tip that's it's not sharp. And there's a little port on the side and the filler comes out there. And the theory behind that is if this is your blood vessel and I come in with a needle, because it's blunt, if it's a needle, it'll puncture it. If it's a cannula, it'll sort of move it out of the way if the tissue's loose enough for that to happen. So that's the first way you mitigate those risks, by using a cannula. The second way is as you inject it, you inject as you withdraw. So you put the cannula in, as you withdraw, you lay a little bead like a 3D printer. So it's not like you stick in one spot. You stick in one spot, you push, 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 push. If you're in a blood vessel, it's going to block that blood vessel. So you're doing it. And so even if you were in a blood vessel, if you're doing it and a little tiny bit as you withdraw, maybe a little bit get in, but it's less likely that that little tiny bit's going to cause a problem. So by injecting as you withdraw, it's less risky. Now, the next thing is knowing your anatomy, knowing where you can inject and where you can't inject. So like here, yeah, there are blood vessels that go up here and go up here, the supraorbital and supratrochlear, okay? Blood vessels that go right here, very important blood vessels, and they do go in towards the brain and the eye. But I operate on those all the time, right? I do reconstructive procedures where those flaps are based on those blood vessels. I know where they are in relationship, so I have an idea. Now, everyone's different, but some blood vessels are pretty standard. They're usually in the same place, but there are little tiny ones. But I might just stick the cannula in first in the area that I want to go, pull the cannula out. If it bruises, if it bleeds, or you know what, there's a blood vessel there. If I come out and there's nothing going on, I feel more comfortable injecting in there as I withdraw. So again, it has a lot to do with the technique, the anatomy knowledge, knowledge of the anatomy, where you can inject, where you can't inject, and how you can inject, and being gentle with doing that. So there is, there's always risk with everything I do. I still do filler. I still do filler under here. I still do a tremendous amount of filler all over the face. We'll talk about fillers in depth at another time. But those are, fillers are really used for embedded wrinkles. So it's 8 o'clock. Again, we'll have another talk on injectable fillers. This is mostly on neuromodulators. If there are any questions, you can email us at info@stanislawmd.com. Thank you for joining us. We try to do this every the second Thursday of every month at 7 o'clock. We do different topics. Again, I think the next topic in January is on otoplasty, which is ear reshaping, but we'll do another one on injectable fillers, go more in depth on injectable fillers. Again, thank you very much for joining us. My name is Dr. Paul Stanislaw. We are in Avon, Connecticut, and have a good night.